You get an infection and you take an antibiotic. Or you have a headache, you swallow a pill. We are just so incredibly conditioned to expect the medicine to do all the heavy lifting.
Right. I mean, the synthetic chemical goes in and the cure just sort of comes out.
Exactly. But what happens when the treatment actually requires your body to heal itself? And what if your body's own internal fuel has been, like, severely compromised?
It's a huge problem in medicine right now.
It really is. So today, we are welcoming you to a new deep dive into a really fascinating biological contradiction. We are jumping into the realm of regenerative medicine, specifically looking at the O-shot, which is a procedure for female intimate wellness that basically uses your own blood to regenerate tissue.
And, the premise sounds so elegant on paper. You extract the body's natural healing factors, you concentrate them, and then you put them exactly where you want a regenerative effect.
Right.
It is a brilliant approach to localized medicine, but biology is, it's rarely a perfectly closed system.
Which brings us to the core mission for this deep dive. We are exploring how a systemic metabolic disease, specifically severe unmanaged type 2 diabetes, actively sabotages these kinds of regenerative therapies.
It's a profound sabotage, honestly.
Yeah, and we are going to figure out how high blood sugar impairs autologous platelet growth factor expression, and ultimately why it drastically reduces the effectiveness of the O-shot.
Right. So, to really grasp how diabetes breaks this process, we first need to understand the baseline promise of the O-shot itself.
Right, how it's actually supposed to work. From the clinic notes in our sources, it's heavily reliant on a process called platelet-rich plasma, or PRP.
Yeah, PRP. So think of PRP as this massive biological concentration mechanism. The procedure basically starts with a standard blood draw from the patient.
Just a normal blood draw.
Exactly. Then that blood is placed into a centrifuge, which spins it at just incredibly high speeds. And the centrifugal force separates the red blood cells from the plasma, which allows clinicians to isolate and heavily concentrate the platelets.
And platelets are, they're the tiny fragments in our blood that usually rush to the scene of a cut to form a scab, right?
Yeah, that's their most famous job.
But they do a lot more than just plug holes, don't they?
Oh, absolutely. They are essentially these tiny biological cargo ships, and they're packed with growth factors.
Okay, cargo ships.
Yeah, and when you inject that highly concentrated autologous serum, meaning, it came directly from the patient's own body back into specific localized tissue, you are delivering this massive payload of those growth factors.
And for the O-shot, the goal there is to stimulate tissue regeneration, build new neural pathways, and dramatically increase local blood flow, right? Which in turn improves intimate wellness and function.
That's the goal.
It sounds almost like magic, but the sources we're looking at really emphasize a hard reality. Because this relies entirely on your natural biology, it is not an instant fix. Like, you don't get the shot on Tuesday and experience peak results on Wednesday.
Definitely not. Initiating a biological cascade takes significant time. You're asking cells to migrate, divide, and build entirely new microstructures.
Right. You're literally building new tissue.
Exactly. So patients might begin to notice subtle initial changes around the 2-week mark. However, the maximum clinical results, like the true tissue regeneration, that often takes anywhere from 3 to 4 months to really mature.
Wow. Okay, so 3 to 4 months. That timeline makes perfect sense, though. But here is the massive caveat that the clinics warn about, and it's basically the jumping-off point for our whole discussion today.
The health of the patient.
Yes. This procedure relies on biological individuality. The clinics note that having a chronic condition like high blood pressure or diabetes doesn't automatically disqualify you from getting the O-shot. But if that condition is uncontrolled, they warn that you might not see any dramatic results at all.
Because the underlying health of the patient's blood dictates the entire success of the therapy. If the raw materials are degraded, the final structure is just going to fail.
It makes me think about gardening, honestly.
Gardening? How so?
Well, it's like planting incredibly expensive, high-quality seeds in completely depleted toxic soil.
Yeah.
The O-shot provides the seeds, the concentrated platelets. But if unmanaged type 2 diabetes has ruined the underlying soil, nothing is going to take root.
That is a remarkably accurate way to look at it.
So I want to pull out the microscope here. We know type 2 diabetes makes up the vast majority of cases, around 90 to 95%, characterized by insulin resistance and chronic high blood sugar. Why is the diabetic soil so hostile to this regenerative process?
Well, we have to shrink down and look at the actual environment floating inside the bloodstream of someone with severe unmanaged diabetes.
Let's do it.
Chronic high blood sugar isn't just passive syrup floating in the veins. It actively alters the microscopic cellular machinery, and that starts with profound oxidative stress.
Yeah.
In a severe diabetic state, the body overproduces what we call reactive oxygen species, or ROS.
Wait, I always hear the term free radicals thrown around in like skincare commercials. Is that what we were talking about here?
Yes, those are the exact culprits. Imagine free radicals as tiny molecular wrecking balls.
Wrecking balls, okay.
They are highly unstable molecules that just bounce around, stealing electrons from healthy cells, causing this huge chain reaction of damage. And in the diabetic bloodstream, there is a massive overproduction of these wrecking balls, coupled with a huge surge of calcium literally flooding into the platelets themselves.
Man, that just sounds like a highly toxic biochemical soup.
It is. And it fundamentally changes the nature of the platelet. The oxidative stress is so severe that it forces the conversion of certain fatty acids inside the cell, specifically arachidonic acid.
Arachidonic acid.
Yeah. The stress converts it into a specific biomarker called 8-iso-PGF2-alpha.
8-iso-PGF2 alpha. That's quite a mouthful.
It is, but basically you can think of it as a massive chemical alarm bell. It literally screams to the rest of the body that huge oxidative damage is occurring. And because of this, the physical structure of the platelet itself actually begins to warp.
Warp in what way? Do they change shape?
Yeah, they start to sprout microscopic hooks on their surface. Hooks.
The medical terms for these are various adhesion molecules, so things like P-selectin, GPI, and GPII/thia. But structurally, you can just think of it as the platelet suddenly covering itself in heavy-duty biological Velcro.
Biological Velcro, wow.
And because of these structural and chemical changes, the scientific literature referred to these diabetic platelets as experiencing hyperreactivity.
Wait, hold on. Let me stop you right there because that phrasing is really counterintuitive to me.
How do you mean?
Well, if I am paying out of pocket for a localized regenerative treatment and you tell me my platelets are hyperreactive, that sounds amazing. Like hyper means energetic, fast, powerful. If I want tissue regeneration, shouldn't a hyperplatelet be working overtime to heal me?
I see where you're coming from.
Right. Why is a hyperplatelet a bad thing for the O shot?
It is entirely understandable to interpret hyper as like super healer. But in this specific biochemical context, it translates to pure chaos.
Chaos.
Yeah, they aren't hyper efficient, they are trigger happy. Trigger happy platelets. Okay, paint that picture for me. What does that look like?
Let's use an analogy. Imagine a highly trained, elite emergency repair crew.
Okay.
In a healthy body, that crew waits calmly in their truck until a very specific 911 call comes in, giving them an exact address to go fix a broken pipe.
Right, they know where to go.
Exactly. A hyperreactive diabetic platelet is like an emergency crew that has been awake for 3 days on way too much caffeine.
Oh boy.
They are panicking, they're responding to false alarms, they're jumping out of the truck in the middle of traffic, breaking windows to look for fires that don't even exist, and just prematurely dumping all their repair supplies into the street.
So they are completely exhausting their resources before they even get to the actual job site.
Exactly. They clump together inappropriately because of that biological Velcro we mentioned. They clot when they shouldn't. And instead of delivering precise regenerative signals, they panic and dump pro-inflammatory factors, like soluble CD40L, straight into the bloodstream.
Soluble CD40L. So rather than acting as a targeted repair crew, they are just running around setting off inflammatory fire alarms everywhere.
Yes, exactly. So by the time the clinic extracts those platelets, spins them down in the centrifuge, and injects them for the O shot, that emergency crew is completely burned out.
Wow. You are injecting exhausted, confused cells that are entirely depleted of their regenerative potential.
They are locked in a state of chronic, low-grade activation that just drives systemic inflammation instead of localized healing.
This is where the story gets really incredible, though. Because the chaos of the free radicals and the Velcro is just the first hurdle, right?
Unfortunately, yes.
The O shot specifically relies on one particular growth factor to actually deliver on its promise of intimate wellness, and that's platelet-derived growth factor, or PDGF.
PDGF is the absolute master architect for building new blood vessels. The biological process is called angiogenesis.
Angiogenesis, okay.
Yeah, and for a procedure like the O shot to work, to increase sensitivity, improve function, and rejuvenate tissue, it fundamentally requires the formation of new, healthy blood vessels to bring sustained blood flow to that area.
Makes sense.
If angiogenesis fails, the entire therapy fails.
So how does diabetes manage to specifically target and neutralize this mast architect? Because it seems like it has a specific vendetta against PDGF.
High blood sugar actually executes a multi-step blockade. The first wave of interference comes from something called advanced glycation end products, or AGEs.
Glycation, I recognize that word.
Yeah.
That's what happens when sugars attach to proteins and fats in the blood, right?
Yeah,
It essentially sugarcoats them and makes them all stiff and dysfunctional.
that's exactly it. The accumulation of those sugar-coated proteins, those AGEs, has been shown to directly suppress the expression of the PDGF gene itself.
Oh, wow. So it attacks it at the source.
Right, before the process even really begins, the high glucose is essentially burning the master architect's blueprints. You simply have less of the critical growth factor even being manufactured.
That's brutal.
But the true saboteur in this system, the mechanism that actively fights the O shot, involves an enzyme called SHP1.
SHP1. Okay. This was the massive aha moment uncovered in the sources, particularly in a really fascinating study from an American Heart Association journal.
It's a groundbreaking piece of the puzzle.
I want to make sure we really unpack this SHP1 enzyme for you listening. Let's look at a healthy person first. What is this enzyme normally doing on a random Tuesday?
Well, to understand the saboteur, we have to understand the normal signaling pathways.
Right.
In a healthy non-diabetic body, when tissue is low on oxygen, a state called hypoxia, it desperately needs new blood vessels to bring in fresh oxygenated blood. The tissue effectively screams for help,
Okay, the tissue is screaming.
and when the healthy body hears that scream, it naturally flips a switch to turn off the SHP1 enzyme.
Wait, why does it turn it off? What is SHP1's normal day job that it needs to be fired from?
SHP1 is a phosphatase. Its entire biological purpose is to act as a brake on signaling pathways.
Oh, a break.
Yeah, it turns things off. So when the healthy body needs to build new blood vessels, it realizes it has to take its foot off the brake. Hypoxia turns off SHP1, which clears the road and allows the PDGF growth factors to rush in and begin constructing the new vasculature.
Okay, I think I see where this is going. The healthy body takes its foot off the brake so the healing can drive forward. But severe, unmanaged diabetes somehow jams the brake pedal down.
It creates a completely devastating cellular short circuit. In an unmanaged diabetic patient, chronic high glucose levels actually force the SHP1 enzyme to remain active, even when the local tissue is hypoxic and crying out for new blood vessels.
So the localized tissue is literally screaming, we need blood vessels, turn off the brakes, turn off SHP1.
Yeah.
But the high blood sugar systemically overrides that localized command. It forces the brakes to stay engaged.
It's worse than just staying engaged. The active SHP1 enzyme goes a step further.
Oh, no.
It physically navigates to the specific cellular receptors, the PDGFR beta receptors, that the growth factors are trying to plug into.
It goes right to the receptor.
Yes. And by binding to those receptors, SHP1 effectively locks the door. It cuts off the crucial cellular assembly lines, specifically the PI3K ACT and ERK pathways, which are absolutely required to physically construct a new blood vessel.
PI3K ACT and ERK. Okay, let me try out an analogy here to see if I have the mechanics of this locked door right.
Let's hear it.
SHP1 is acting like a wildly corrupt bouncer at a nightclub.
Okay, have that.
The growth factors, the PDGF, they're the VIPs. They have the tickets, they have the money. They're supposed to get into the club to repair the tissue and build the new vessels. But the systemic high blood sugar acts as a massive bribe.
Yes.
It pays off the bouncer to keep the doors locked, no matter how loudly the tissue inside is screaming for help.
That captures the molecular reality perfectly. The high glucose is the bribe, SHP1 is the corrupt bouncer, and the growth factors are just left standing on the sidewalk while the tissue inside degrades. The regenerative signals simply cannot penetrate that blockade.
So what is the ripple effect of this? We are looking at a patient who paid good money for the O shot, their blood was spun down, the PRP was injected, but because of their unmanaged diabetes, the bouncer locked the door and the PDGF signal was totally blocked. What physically happens to the tissue in that treatment area?
The physiological fallout is a phenomenon known as vessel regression.
Vessel regression.
Yeah, because that specific architectural signal from PDGF is blocked by the bouncer, a vital group of cells called smooth muscle cells fail to receive their instructions.
Smooth muscle cells, or SMCs, where do they fit into the construction project?
Think of them as the bricklayers. When new, tiny capillaries first begin to sprout in the tissue, they are incredibly delicate. I mean, they're little more than thin tubes of endothelial cells.
Super fragile.
Very fragile. So smooth muscle cells are supposed to migrate out to these nascent capillaries, multiply, and wrap themselves around the outside of the delicate tubes.
Oh, they reinforce it.
Exactly. They provide the structural scaffolding that stabilizes a fragile capillary into a mature, durable blood vessel that's actually capable of handling blood pressure.
But because the bouncer blocked the PDGF signal, the bricklayers never get the memo that a job site is ready for them.
They never show up. And without those smooth muscle cells to surround and reinforce them, the newly formed capillaries remain naked.
Naked capillaries.
They are leaky, fragile, and totally structurally unsound. They simply cannot withstand the physical force of blood pumping through them. Consequently, they eventually rupture or regress entirely.
That is just a heartbreaking piece of biology.
It really is. The body expends the energy to begin building the new blood vessels, but because the scaffolding never arrives, the entire structure just collapses back into itself.
The localized tissue tries so hard to heal, but the systemic disease pulls the rug right out from under it. And, as if that wasn't enough, the sources outline one more incredible layer of irony regarding insulin itself.
Ah, yes, the insulin receptors.
Right. We constantly hear that the hallmark of type 2 diabetes is insulin resistance. We usually think of that in terms of muscle or fat cells just refusing to absorb glucose from the blood.
Which is true, but what is far less commonly known is that platelets themselves actually have insulin and IGF-1 receptors on their outer surface.
Wait, platelets need insulin. I always thought insulin was just the key to let sugar into a cell for energy.
Yeah.
Why does a tiny blood-clotting fragment need an insulin receptor?
Because in a healthy, balanced system, insulin acts as a calming mechanism for the platelet.
A calming mechanism.
Yeah. Normal insulin signaling tells the platelet to release compounds like plasminogen activator that actually help break down unnecessary clots. And it suppresses internal chemical pathways like KMP concentrations that lead to hyperactivity.
So chills them out.
Exactly. It essentially keeps the emergency repair crew relaxed and focused.
But the severe diabetic patient is insulin resistant, meaning there might be massive amounts of insulin floating around in their bloodstream, but the receptors on the cells have become completely deaf to it.
Right. The platelets are starving for the stabilizing influence of insulin, but they literally can't access it. So let's look at the totality of the diabetic platelet here.
It's a mess.
It is actively being battered by oxidative stress and free radicals. Its growth factor signals are entirely shut down by the SHP1 bouncer, and it is completely cut off from the calming signals of insulin that it desperately needs to just function normally.
Bringing this directly back to you, listening right now. This journey from the macro clinic to the microcell is exactly why a treatment like the O-shot fails in cases of severe unmanaged diabetes.
The biology just won't allow it.
Right. You are extracting a highly compromised, chemically stalled, chaotic system. You are spinning it in a centrifuge, injecting it back into the body, and then asking it to perform peak athletic feats of vascular regeneration. The body simply cannot stabilize the new blood vessels required for the increased blood flow and intimate wellness that the O-shot promises.
It is the equivalent of asking a fundamentally exhausted, starved, and chemically blocked biological system to do heavy lifting it no longer possesses the pathways to achieve.
You just can't out-inject systemic disease.
Exactly. Systemic metabolic health is the absolute non-negotiable prerequisite for localized regenerative medicine.
Let's briefly trace the steps of this journey one more time, because unpacking how type 2 diabetes breaks autologous therapies is incredibly complex.
That's a lot of moving parts.
Yeah. We started with the realization that the O-shot isn't a synthetic magic wand. It relies entirely on your own biology. But unmanaged diabetes triggers a relentless chain reaction.
Starting with the wrecking balls.
Yes, the oxidative stress, creating those chaotic Velcro-covered platelets that exhaust themselves on false alarms. Then, the chronic high glucose bribes the SHP1 enzyme, weaponizing it as a bouncer to block the crucial PDGF growth factors.
And blocking the PI3-ACT pathways.
Right. And finally, without those growth factors giving the architectural orders, the cellular bricklayers, the smooth muscle cells, they never show up. So the new blood vessels remain naked and fragile, eventually collapsing entirely.
It perfectly illustrates why we can never look at a localized treatment in a vacuum. The systemic environment always dictates the local outcome.
It really does. Now, before we wrap up this deep dive, digesting all of this microscopic cellular sabotage leads to a really provocative thought, like a sort of biological what if for the future of medicine.
Oh, I like where this is going.
We didn't see this directly in the clinic notes from the sources, but understanding the mechanisms definitely inspires the question.
Right. If we now know the exact mechanism of the sabotage, if we know for a fact that high glucose uses the enzyme SHP1 to lock the doors and block those regenerative signals, could future medical treatments involve basically pre-treating a diabetic patient's extracted plasma?
Think about what that would look like for you as a patient. You go to the clinic, they draw your blood, and they spin it down into that concentrated PRP. But instead of just putting it straight into a syringe to inject back in for the O shot, the clinician treats that plasma in a lab environment first.
What if science could introduce a highly targeted biologic compound into that extracted plasma that permanently switches off the SHP1 enzyme before it ever goes back into the body?
It's mind-blowing. You would theoretically be bypassing the entire diabetic blockade. You are chemically firing the corrupt bouncer, ripping the locks off the doors, and restoring the regenerative power of your own platelets, even if your systemic blood sugar is still elevated when you walk out of the clinic.
It would be an absolute game changer for autologous therapies across the board. We could give those regenerative seeds a fighting chance to take root by chemically overriding the toxicity of the soil.
That is the kind of frontier medical science that makes looking into these systems so incredibly rewarding. It's always amazing to look under the hood, to challenge our assumptions, and to keep questioning the intricate mechanics of the human body. Thank you so much for joining us on this deep dive. Until next time, keep exploring.